Now is my guests tonight on the bench, Dr. Gigi and Dr. Lois. We know each other that well, that's what I call them. And when it comes to COVID-19, folks, they're no better experts. And I know you have many questions, and I do too. And my first question, Dr. G, let me ask you this. The positivity rate yesterday was something like 13.1%. Nice drop to something like 9-point-something% today. What does that mean? Is there a new wave? Is there not a new wave? What's going on?
Well, number one is that the positivity rate will keep changing because it depends on who was tested, how many tests were done, and from where. Because it's a mix. You know, maybe today you might have more travelers being tested than contact traced. You know, so it's a mix. I think what we need to look at more is not the daily headlines, but the trend lines. So you need to look at over time and say, where is it going? That's why we do something called 7-day moving average. So you look at 7 days, you average, then you keep doing that. Then you see the trends. But are we on the cusp of a fourth wave? I would say yes, we are. If you look at what has been happening now and you listen on the ground, you hear that ICUs are starting to see, hospitals are starting to see a few more people coming in. I saw a story about Mombasa, though there was a bit of controversy around it. But generally, yes, and we expected. There were projections, there was modeling projections saying we might start the fourth wave end of July, beginning of August. So yes, we are.
Dr. Lewis, do you agree with that? Is there a fourth wave looming? And also ICU beds, we are hearing the same story. They're filling up.
So over the last month or so, we know the western part of the country has had a significant number of cases. We know that most of what was seen there was the Delta variant, or the variant that was originally described in India, which is known to be transmitted a little better or more efficiently transmitted. So with that, once you have that circulating in the community, you expect that you'll begin to see a rise in cases. If you look at Nairobi, for example, we know we're beginning to see a small rise in cases, and not just mild cases, but even the severe cases, we're beginning to see a small rise. So the direction it goes to depends on what we do with that information. If there's a lot of public gatherings, then we'll definitely see a large rise in cases. But if we try and keep that to a minimum, then the hope would be that we do not overwhelm what we have already. That's always a concern, that you have cases that you can manage without filling up all the available ICU space.
By the way, Doc, who decides on the waves? Third wave, fourth wave, who decides?
I'm not sure there's someone sitting somewhere deciding, but it's really just observing the trajectory, what's happening with time. So for example, if you look at last year, when the COVID first came in, we sort of had a high number of cases, it went down. Come around July, we had a high number of cases that came down. Towards the end of the year, October, November, again, we had a large number of cases. And this year, March, April, we had a really large surge. So it's really just observing the trends in community. Many times, what determines whether we're having a wave, sometimes it's because of human behavior. So when we open up and we begin to have parties and rallies and lots of gatherings, then we'll have spread. Sometimes it's because we introduce a new variant that people haven't been exposed to. So those who are vulnerable then get the new variant.
Yeah. Dr. G, I saw you laughing there when I mentioned who determines
You see, a wave is a result of increasing positivity. That's what it is. It's a result of, if you have contacts, and the contacts, you have a high multiplication rate. You have a high multiplication rate for the virus, and therefore you have more people being infected at a go. Then the positivity rate out of the contacts, and the contacts could come from this movement thing, and the rate of the infection at contact, what you call the contact, could be driven by the nature of the virus itself. That's why the mutants, like the Delta, is infecting. So there are many factors. So when the positivity rate starts going up, then the cases go up, and that's the wave. So it's a result of all these other factors. But I think the warning shot I would like to send is that we've seen across the world where the Delta virus is involved, the rate of the rise of the wave is so much faster than before. In some cases I've seen it's 50% faster, 88% faster. Netherlands had relaxed their measures just the other day. They have had a 500% increase in a few weeks. And now they're like, we wish we did not relax. I heard the Prime Minister actually apologizing to the public. If you look at Africa now, the third wave of Africa is straight line like this. Straight line. The highest peak we had in Africa was maybe 35,000 cases reported a day. Now we are about 45,000, and it is a straight line like a wall. To move from deaths from about 2 to 3 million took twice the time it's taken for the world to move from 3 to 4 million. So you are seeing that it's, even now you can see we are seeing a small rise. It can just take 4 days, and then we are like this. So we should remember that.
And yet at the same time, you see the rallies in Kiamba and Muguga. Dr. Lewis, you're talking about dropping the ball. Look at that. There's no masking, there's no social distancing. Is that a cause for worry?
It's a cause for worry because we haven't vaccinated people. If countries that vaccinated, like Netherlands, are having to consider now a lockdown because they opened too soon, now the US, in areas that are not vaccinated, you know, some of the states that are not vaccinated, are seeing a rise. The world is seeing a 55% rise in cases in, you know, in a few weeks. So we should not drop our guard. The danger lurks right now is with us. So what we have seen in Kiamba and other places is absolutely unacceptable under these times.
Yeah, and then Dr. Lois, this week, schools close.
Yes.
Kids will go back to school for the new year next week, where the entire school population will be involved, from preschool to grade 5 to Form 1. Yeah. Is that also a cause for concern?
Definitely there's some concern. Every time there's people coming together, we expect us to see a small rise. Looking at what's been happening since schools opened, we know that there are times when we've observed a little more cases in schools. I guess with schools, sort of the only thing that we've noted is that children tend not to get severe cases, so that's a good thing. There was a move to vaccinate teachers, so hopefully all teachers have been vaccinated so that the school community is a little better protected. But there are other things that happen when schools open. There's increased transport, there's increased crowding in transport, bus termini and the rest, and those are potential areas for transmission. So we must take extra precaution, including wearing of masks consistently, for example.
Yeah. When you look at you talk about various variants, right? Delta variant, UK variant. Which one is more, would you say, dominant or more prevalent here?
So right now we know in Kenya, the last data I looked at, I think we are saying probably the original, what we call the wild variant, is still predominant. But the Delta variant is rising. So you see the trend of the Delta going up, but the predominant one is still the old one. But the Delta variant, the speed at which it will overtake the old one from other countries is very high.
And we know that in some parts of the country, already the Delta variant was predominant. For example, in the western part, Nyanza, you know, areas around the lower rift already had more predominant Delta variant.
Is it rising?
In terms of the percentage?
Yes.
Yes. So I remember looking at some data that was presented by Cambridge CDC Labs, and they were looking at the surveillance around Western and Nyanza areas. And we were asked in the beginning, we had, you know, our very original variant. At some point, they had a bit more of the UK, then a bit of the South African, but more recently, it was largely just the Delta variant. Yes. So even in Nairobi, where we had more of the original variants, now we're beginning to see more of the Delta variant. And we're beginning to see cases from travelers from Western coming in sick with probably what would be the Delta variant.
In that way, spreading that way, obviously.
Yeah.
What's the difference between what's happening in Kenya and what's happening in our neighboring countries?
So if you look at what's happening in Uganda, for example, it would probably be very similar to what has been happening in the western part of the country. And if you look at Central Africa, so DRC, Zimbabwe, Zambia, all reported a very sharp, very steep increase, probably 500% increase in most of those countries over the last several weeks. So it's probably the same thing that's circulating in that region. Neighbors tend to have similar attributes, you know, and there's going across borders. If you look at Busia and Uganda, there's a lot of cross-border movement. So it would probably be the same variant that's going around in that area. But the one thing we know is that we've seen a sharp increase in cases. Uganda, Western Kenya, Uganda, and the surrounding countries as well.
Yeah, yeah. And there's a big surge in Southern Africa. So you look at Namibia, Zambia, Malawi,
even
you know,
Mozambique.
around there, Mozambique. There's a huge surge. So again, that's and they had a lull for a very long time, other than South Africa. So
why is that?
I think we've tried to explain this a lot. You see, a few months ago, at the beginning of last year, people kept saying, India, Africa has been spared the virus. Journalists would call and say, why is India not seeing, why are we not seeing deaths? But now no one can ask that question anymore. So why did India end up in the situation they did? And I think it has a lot to do with the tipping point, which is about movement, which is about population urbanization, and also the variants themselves, because they will linger and the virus will be multiplying in different people and moving to different people, and they're making errors until one error will change the nature of the virus, and therefore the virus becomes more. So there could be multiple factors that related to human movement, urbanization, and then also the virus itself and behavior. In India, there was the Christian thing, the religious ceremonies, there was politics. Here it could be politics, it could be this or that, and then you just get a trigger, and when you get to a threshold, then the virus now just keeps going, and then you have a major catastrophe.
Dr. Lois, we just came back from Juba literally this weekend, and over there testing very professional.
Very good.
We were really impressed. And when we asked them how many cases are they getting a week, they told us an average of 2.
Okay.
I mean,
so, that's an interesting one. I'm not sure exactly what's happening in Juba, but what determines how many cases you get? So one, is it just cases because they tested positive? That will be very dependent on how much testing is happening. A very good marker, though, is usually how many people are in hospital, very ill, how many people require oxygen, and how many people are dying, because that goes beyond testing. If someone requires oxygen, they require oxygen whether or not they are tested. So looking at hospital rates and number of people dying is usually a very good marker of what's actually going on in the community. And the reason I say that is because only a small percentage of people will die. A small percentage of people will get severely ill. So by the time you have a number of people severely ill, it tells you that the burden of disease in the community is quite high. But many of those people probably don't have symptoms or are just mildly ill. And especially in this season, everybody will say, I have a homa. It's cold, everybody's sniffing. You never know how much is going on there.
It is quite cold, actually. Dr. G, in the beginning, about a year ago, when people like I first got the virus, most of us were asymptomatic. And the virus was mostly affecting older people. Has that changed in the last year?
I think I would really like to hear Lois's opinion on this, because with all the people coming to the hospital where you're working, have you seen a change in the age profiles and the risk of age and what you call comorbidities? Maybe a comment from you.
So I think it's sort of remained the same. The people who get the most severe illness are still older male with comorbidities. But when you have a lot of people sick, then you'll begin to see younger people also coming in with severe illness. And it's really just a marker of how many people are sick in the community. When you first introduce it, the most vulnerable are probably the ones who will come in earliest. And as spread goes on, it will get to those who are a little less vulnerable. So if you introduce a new virus into a community, you'll get the oldest, the ones with the highest number of comorbidities, because they just do not have, the immune system is not strong enough to fight. And then as time goes on and spread goes on, then you start seeing the slightly younger people, those who are a little more fit, to then get affected. But overall, the trend has sort of remained the same. Occasionally, there's been concern that when you bring in, especially when we have new variants, are we seeing slightly more severe disease or not? It's often not very easy to tell unless you're tracking this, you're tracking populations over time. Because many times it's that when the new variant comes again, it's the most vulnerable who may come in and they may get more severe disease.
Okay, let's get to your favorite subject, Dr. Ari. Vaccines.
And it's for a reason, it's really our last bullet.
Like literally. So AstraZeneca has been the main vaccine here. How effective is AstraZeneca against the Delta variant? Because there's some European countries that are saying we're not going to use AstraZeneca when it comes to the Delta variant. Is that true? Is that?
You see, the reality is this, that first we need to tell the people who are watching us now that when you measure vaccine effectiveness or efficacy, you want to measure protection to severe disease. not general population. Does it stop mild, moderate symptoms? So if you look at whether the vaccines stop severe disease which requires hospitalization, all the vaccines operate at about 100% effectiveness. But then we know that, as you now start looking at the total population, they are a bit lower. Now, when you come to variants, the original variant, that the Alpha variant, is more responsive to vaccines than the Delta variant across all of them. It's not about AstraZeneca or Delta. So whereas one maybe had 95% effectiveness against Alpha, then it will be probably 70-something against Delta, and one that was 75 might be 67. So they have all lower effectiveness against Delta, but they have high effectiveness to actually reduce the rate of progression to severe disease. And that's the key message, so that people don't become statisticians.
And maybe there's new data now coming out of the UK where they've looked at people who are hospitalized with Delta variant and looked at, those who are vaccinated versus those who are not vaccinated. And they're finding that actually vaccine efficacy for AstraZeneca against Delta variant is actually fairly good in protecting against hospitalization and severe disease. Efficacy after the first dose is lower than after the second dose. And indeed, we've had people who had their first vaccine and have come down with COVID, but often not too severe. A few may have been severe, but generally, there's some protection even after the first dose. And now we're seeing increasing data, especially from the UK, because they have an excellent surveillance system that's telling us about effectiveness against the Delta variant.
Okay. Last time you were here, Doc, you mentioned that we should not mix vaccines. You should never have a cocktail of vaccines. WHO yesterday said the very same thing. Vaccines should not be mixed. You agree?
Well, there's an issue of studies and research and evidence, and then there's policy, you see. Now, the difference between these two things is adequate information, adequate data, adequate evidence. So there are people, we now have studies that say, you can mix. We have studies, UK, we have Germany, we have this and that. But I think what WHO is saying is that there is not adequate data to make it policy. And policy changes can also be informed by other factors, and those factors could be about the ease of administration or the difficulty of administration and order. You can actually also decide policy based on those other factors. Like, for example, many people said we should test people before they go for their COVID shot. But the policy position was, don't do so, because then it complicates the vaccination and there's no major benefit. So there is evidence saying mix and match could work. Some people are worried about that. Mix and match could give you more severe side effects. But generally, we are waiting for WHO, which is the one that sets the norms and standards for the countries, is waiting for adequate data and evidence to make a policy decision. For now, WHO says no mix and match.
So,
but Lois may have a different opinion.
I think it comes down to an issue of access to vaccines. And we're seeing studies that are now beginning to talk about this mixing. I mean, one of the biggest studies has looked at giving AstraZeneca, then Pfizer, or Pfizer, then AstraZeneca. Those are the two that have really been studied for which we have data. But it's about access, and I think such work should really be encouraged as long as we have issues with access, so that whatever is available at that point, can it be safely used and will it work? And I think whatever work will show us that combining vaccines is good, I think should be really, really promoted. And I think I would say to WHO, maybe it's time to rethink that stand and say what can we promote that makes the highest number of people vaccinated with the vaccines that they have access to. So the issue of access, if not sorted, then we have to think about what are the other options beyond the optimal of using the same vaccine.
All right, so let me go on.
Yeah, you see, the issue that Doc raises are critical, but WHO is actually working on the fact that in the next 4 months, the world is going to be flooded with vaccines, you see. So that information is also available. If you look at the Serum Institute of India, their production capacity per day has gone up by almost 50%. If you look at now countries in the north, they have actually got adequate vaccines. They're now pushing them, okay? If you look at Kenya, now we are ordering 13 million doses of J&J. They are going to be here. But even by the time they're here, we'll have received more AstraZeneca, more Pfizer. So there is not going to be a challenge with access in the next 3-4 months.
But then there was that lull when COVAX didn't deliver, right? And that lull is what we're paying for.
And that's what and that's what concerns all of us. And that lull was created by nationalization of the plant in India. But right now we are seeing that actually vaccine doses are mushrooming everywhere. Even COVAX itself is asking countries, we have Pfizer, when are you going to pick it? You know, Kenya is going to get 2 million doses of Pfizer probably in the next 1 month or less. We are going to get 13 million of J&J. Our problem now will no longer be administration. And maybe this is also informing that policy decision. It's going to, it's no longer going to be access to doses. It's going to be, can we actually administer the vaccines fast enough? Now, if you start to mix, then you start to have a problem with who got what, because we are not sophisticated enough in measuring that. So those are so the science is saying yes, the policy is saying not yet.
Wait first.
In the meantime, if we do get the J&J, Johnson & Johnson, that's only 1 dose.
That's only 1 dose.
So what if one already has 1 AstraZeneca in them?
You wait for your AstraZeneca. So as we said, we're looking for data to support. We have some data now that would potentially support maybe AstraZeneca with a Pfizer, but there's no data, and I'm not aware of any study globally that has looked at combining Johnson & Johnson with another one. So if someone has had AstraZeneca and you haven't had your second shot yet, when Johnson & Johnson comes, wait a little bit, because more AstraZeneca will come, some Pfizer will come, and those we have data that will work. So let those who've not received get the Johnson & Johnson.
Yes, but I would like to, sorry.
And maybe the other thing is also to tell people that these vaccines all work. So people shouldn't feel like, I got an inferior vaccine, let me just run and get Pfizer when it comes. If you got your 2 shots of AstraZeneca, that's sufficient to protect you. And that, I think, is important information as we begin to get in new vaccines.
And that message is really important because in the next 2 months, or 2 actually, Kenya will be giving J&J, AstraZeneca, and Pfizer at the same time. So we must tell and remind the people that all vaccines work and no vaccine is better than the other, okay? That they all protect you against severe disease that requires hospitalization. So there should be no rush at somebody now taking a taxi or a boda to go to a hospital where they hear there is Pfizer, because take the vaccine that's near you that you can access is the best vaccine for you. And it is true we are going to be having 3 vaccines being offered to Kenyans in the next 2 months.
The New York Times had an issue with Johnson & Johnson the other day. You heard about that, huh?
There was this report, actually it was flagged by the FDA, about some rare neurological side effects. So there's something we call GBS. Basically, it affects the nerves. So people may get weak or they may have a problem with sensation. And there have been about 100 cases noticed in the US, but this is 100 out of many millions that have been vaccinated. So it's still a bit rare, but because with vaccines you're giving it to someone who is well, every side effect must be investigated. So I think as time goes on, we're going to be getting a lot more data. And it also points to the need for countries to be very vigilant as they give vaccines to ensure that people have a way of reporting any side effects so that we know what's happening in the country.
Dr. G, you mentioned a moment ago that we're going to be spoiled for choice in the next few months. And no mixing and matching.
Not yet. Not yet.
Jeff, don't go and mix.
Okay. But with the Delta variant, the way you say, so prevalent, right? Isn't that the virus going to be susceptible to that? I mean, will it be able to tackle the virus?
Yes, it will. Evidence now. I mean, she's just talked about the effectiveness of AstraZeneca against the Delta variant in UK as a study. So we have no worry for now about vaccines, the viruses escaping the vaccines that are available. But there's no telling whether there will now be, we have 26 numbers of the, letters of the alphabet, the Greek alphabet. So we are only maybe about number 11 or 10, something like that. So we have a long way. Exactly. So we have a long way to go. So there's no telling whether another variant will come that will actually escape the vaccine. So we can't say never. But for now, for the variants we have, evidence shows that it is effective against the viruses that we have.
Yeah.
Dr. Lewis, some people have already missed their second dose because AstraZeneca is not available. And then they've waited, I guess they're wondering, what's the waiting period?
That's a good question. So, again, one of the things that everybody has to realize is that this was a new disease, so we are learning as we go along. At some point, it may look like shifting goalposts, but it's because more information becomes available, and we have to be open to learning as time goes on. Right now, there's, again, we have evidence from various studies, and one of the very informative studies looked at giving the vaccine, 8 weeks, 12 weeks, but they also went on up to about 25 weeks, which is about 6 months after the initial dose. And they're showing that if you give the second vaccine up to that period of time, the immune response is even higher than if you gave it at 8 weeks, for example. So that gives some confidence that even if you have to wait 4 months or 5 months, you're still going to be okay. If anything, you'll probably be better off than me who got it at 3 months, So I think maybe then people shouldn't be too anxious. And that's important because if people feel they've waited 4 months and J&J comes, then they may want to run in, and take advantage of this one.
So
this one, we're saying there's data to show that you are okay, but you still have to take precautions. So don't remove your mask just because you got 1 dose, because we know that's not fully protective. But it's okay to wait a little longer, and the immune response elicited then will probably be better than if you'd gotten it earlier.
Good point. Dr. G, there's someone who said that if you get a 3rd dose of Astra, you might have full immunity.
Well, that's called non-statistical data, because that's one person saying I could get a 3rd one. But there are discussions about giving a 3rd shot. So that study is going on, and some countries are saying they're going to actually give a 3rd shot. So it's not too far off. But for now, for us, we are recommending that you take 2 doses, because the 2 doses, scientific evidence shows they're effective. And let me reassure those who haven't had, because I also wear the hat of I sit in the National Task Force for Vaccines, that we have assurance that we are going to be receiving over 400,000 doses of AstraZeneca in the next few weeks. So no one should worry. If you got your 1st dose, you're going to get the 2nd one. Don't worry, don't panic, don't rush to get something else. Just get your AstraZeneca. It will be here for you.
And that 3rd dose story, I mean, there's a lot of discussion going on globally about it, but I think it would appear morally wrong to give a 3rd dose when there are people who haven't had a single dose. Yes. So I think as those discussions go on, the first step would be to ensure that everybody has something in them before we can start thinking about extra doses for those who already got there too. So I really hope that as those discussions are had, we think about getting everybody to the same level. Equity, really.
Stop getting greedy, That's what she's saying.
You'll grow fat out of vaccines.
That's a very good point. Look, we've only vaccinated a little over 1 million people with the 1st dose. 500,000 with the 2nd dose. Why?
Why?
The man on the task force. Let's ask, why only?
I was waiting for Lois to answer for me this question, And then I get to, anyway, you see, the thing was this. So there are 3 sources of vaccines. One source is COVAX. That's the COVID vaccine facility, which provides doses to many countries, 92 countries. The second source that came later was the Africa Union, that said, because COVAX is not giving us enough as we need, Africa Union got together under Cyril Ramaphosa and said, we are going to order vaccines through something we call AVAT. That's the second source. And the 3rd source is donations from countries that booked early, and they locked the entire global market, and now they're like, oh my God, we are holding too much, please give them away. So those are 3 sources for Kenya. Now, if you look at COVAX, we had projections that by the end of this year, would have vaccinated probably 9 million people. Then India happened. So COVAX was left without any vaccines. So that's the reason why. Because the projections that were done, including the phase 1, phase 2, were based on the promises, the signed promises of that delivery. So what has Kenya done? So COVAX was paralyzed for a long time until now. Now they have started to deliver Pfizer, they have started to deliver some AstraZeneca. But the second window, which is the Africa Union, requires countries to purchase. COVAX you don't purchase, they're free. Okay? It's a global arrangement. So Kenya has then gone ahead and said, we can't just wait for COVAX, we are going to purchase. So Kenya has purchased through Africa Union 13 million doses of J&J that are going to be here in August. And the 3rd window is donations. Kenya has received donations from France, Denmark, we are going to get from UK, and US, Pfizer. So those 3 windows are now coming to solve the problem that you are raising. So it was a kind of a lull because of the challenges in India.
Lull before the storm. I want to take a break, folks, and come back. There's so many more questions. Look, the UK is lifting restrictions next week. They're saying people don't have to wear masks if you've had 2 shots. We still have to wear our masks.
And they just had the euro, so we are not sure what will happen.
Yeah.
Are we expecting another lockdown? That's the other question. You know, you're on the task force. Are we expecting another one? Yes or no?
I don't know, because we have to wait for that wave we are talking about earlier and see.
We'll talk about why it may, not that it will be necessary, but what informs the need for such measures. Yes.
Oh my goodness, so many questions. So many answers to them. Thank you, guys. Keep tweeting. At Koinange Jeff, at Citizen TV Kenya, we're talking to the experts themselves, Dr. Lois Ombajo, Dr. Gidenji Gitahi, both in the house answering your questions. What are they? Keep them coming. At Koinange Jeff, at Citizen TV Kenya. Hashtag is JKLIVE. JKLIVE takes a break. We'll be back in a moment.